All right, so today's agenda, I'm going to talk about macro MIPS 2018, what's new in 2018. We're going to go over some performance categories and then talk a little bit about the final score and submission, which seems like a long ways away, but it'll be here before we know it. So some of the biggest changes in 2018, I'm going to go ahead and list and kind of walk through some of those. Some may apply, some may not, but here they are. The first one's going to be virtual groups are a reporting option. Now, basically, this reporting option, you had to self-nominate by the end of 2017. So if it didn't happen, it's not anything that you can do for in 2018 to move ahead on that, but it may be something down the road that you're thinking about as well as that comes on. There's also new exemptions and considerations for small practices, automatic reweighting of ACI for certain extreme uncontrolled circumstances. And then some cost category is formulary is basically the cost category, which we didn't have to technically worry too much about last year, is now being introduced. And it's going to be weighted in at 10% of the final MIPS score. So I kind of want to talk about that a little bit to make you aware that it is happening and what it's all about. So again, for the review of the MIPS eligible clinicians, 2017 through 2019, is what we've been doing is physicians, PAs, nurse practitioners, clinical nurse specialists, certified registered nurse anesthesiologists. And then thinking about 2019 and forward, you can see where they're going to bring on physical, occupational, speech, language pathologists, audiologists, nurse midwives, clinical social workers, clinical psychologists, dietitians, and nutritional professionals. So that's all down the line. Excuse me, coming up in the future here. So if you're in a situation where you've got certain types of those employees already there working or you're planning on it, those will come into play in all this reporting in 2019. MIPS eligibility exemptions. The newly enrolled, same as it was last year, and moving there. If I'm newly enrolled in Medicare with my Medicare number, I can be exempt from this. The low volume threshold, you can see, has been raised. Information in there from previous, and so that's one thing that you want to pay attention to in this year. If you barely made the threshold last year, you want to make sure that you will be able to do it this year. There's nothing to keep you from reporting on that, but just to understand where you are on that threshold. And then the advanced APM participation as far as those exemptions go. Eligible clinicians that can participate as a group, which we've been doing this year, which basically means as a 10 level, multiple providers in one, eligible clinicians, I should say, under one tax ID number, or as an individual, which again, many of the individual providers have been reporting, or as I said earlier, as a virtual group, which allows for bringing individual providers together and to be able to add all their information and to report that way. Keep in mind that the participation level must be the same for each performance category. And for example, if you report quality performance category as a group, you must also report the cost, ACI, and improvement activities as a group. You can't pick and choose on that, same as it was this year, to be able to how you're going to report moving ahead in 2018. So a little bit on the MIPS virtual group reporting is it's a combination of 2 or more 10s that aggregate their data to report as a group. So basically who can participate is going to be solo practitioners or groups of 10 or fewer practitioners. Participants must exceed the low volume threshold. So there again, if you've got somebody that thinking they could in the future join one of these virtual groups, that low volume threshold does play a role in that, so it's going to be important to understand that, whether they can participate or not. And then how to participate is, like I said just a little while ago, for this year they would have had to self-nominate by December 31st of 2017. So if that hasn't happened, I mean, it's not going to happen in 2018 for you at all, but it is new for this year. All right, and then the information on the self-nomination process can be found in the virtual groups toolkit provided by CMS. Information, and I've got in the back of this slide, I've got resources that you can go to and look up that information on links once you get the slide deck. So also what's new is the small practice provisions. Small practice are practices, again, of 15 or fewer clinicians, 3 points on quality measures that are below the data completeness threshold. Bonus points are added to the final MIPS score for small practices. And then $100 million have been dedicated to small practice assistance, education, and guidance. So there again, I mean, there's a lot of education and guidance on the government side on there. So really take advantage of that so that you can get the most out of this program and understand what's going forward and moving forward on it. There's a lot of help out there, and so it's worth exploring what you may need. So some comparison into the legacy programs. This is nothing new. It's the same thing we've done in 2017. Is the PQRS is now the quality data. The quality improvement is the improvement activities. The ACI is going to be the meaningful use, and then the cost is the same as the value modifier that was used before. So you may or may not have participated in that program, but that's where the cost is coming in, and now this year will be included in the overall score information that comes on. So changes to the performance categories. So to begin with the quality performance category changes in 2017, you can see that in 2017, it was 60% of the MIPS final score. Now, because they've included the cost into this program, it's now worth 50% of the final score. The data completeness threshold is 50% of all payers. Again, moving into 2018, the data completeness threshold is now going to be 60% of all payers. So increased information that goes on. Performance period for 2017 could be 90 days to a full year. And now in 2018, it is a full year. So, I mean, we're well into the first quarter of the year. And so it's important that sites continue reporting. And we'll talk more about this as to what they're doing on, but they really need to, be active on it. Even though we're kind of winding down 2017, they will be required to report all year for the quality data. Then the minimum score for a measure is set at 3 points, and now in 2018, the minimum score for a reported measure is set at 1 point, except for small groups will still do the 3-point information that comes onto it. So you do get a little bit of benefits of being the small practice information that comes on, but notice that those changes have come out. And then top-down measures, more difficult to perform well in, but no additional restrictions. You can see in this year, 2018, there's been 6 highly topped-out measures identified that will have a total points cap of 7 points instead of the 10. And I've got a list of those here coming up, information that comes on to that as far as those highly topped out. Again, this year, the quality performance category is going to be up to six measures to be reported. One must be an outcome measure or high priority measure if outcome is unavailable. Alternative, a specific measure set or subspecialty measure set may be reported. So not a lot has changed on that to move out, keep on going and doing what you're doing if those were working for you. Top-down measures. Basically what top-down measures are MIPS quality measures where historically the performance has been so high that meaningful distinctions can no longer be measured. So as a result, CMS just doesn't find that these measures are really useful and are going to start phasing them out. What this really means to you is top-down measures in the first place will not just be simply removed from the measure list from one year to the next. So you don't have to worry about all of a sudden a measure dropping out of the mix there. They just and becoming unavailable. But you will be at a scoring disadvantage if you choose to submit data for these topped-out measures. For measures with benchmarks that have been topped out for 2 or more consecutive years, CMS will apply a scoring cap of 7 points and then phase them out over a 4-year period. So, right now we're kind of in the second year. So it's not going to happen all at once at us, but it's something to kind of pay attention to as we start moving forward this year and in the future as to topped-out measures that may be something that you've been reporting on and are going to start going away, because basically what that would mean is if you're thinking you're submitting 100% performance rate and you have topped-out measures, that could earn you like 7 versus 10, which would drop you down to like a 70% top score. So it's just a matter of understanding that and being able to best choose your route of what you're going to take on these measures. You may overall decide that it's still, to your advantage to submit data for topped-out measures as part of your measure set. But in order to understand how the score will turn out, you'll need to model the topped-out measures with the appropriate scoring caps. So basically just understanding that if you're going to go ahead and report some of these, you probably would want to add something more onto it for more measures to bring that measure up. Don't be relying on those particular ones that are going to come out. Now, this is the kind of thing, as I kept wanting to say it, is when I was doing this, I was like expecting to see those, medication reconciliation or something that I know that a lot of people are using. These are the measures that are going to be topped out in 2018. So they're not a lot of measures that are real on the top of the list, since most of what we were using were in the EHR up until 2017. But it does affect, these top two ones are going to be like orthopedic surgery, thoracic surgery information that goes on. Those two would affect those. So if those are something that you're reporting on now, just understand that this is going to happen. Pulmonary medicine, you're going to have the chronic COPD, long-acting inhaled therapy. This is a measure that's going to be basically topping out in 2018. So just if that's something that you're using and this is the kind of discipline you're working under, just to be aware of it. There's one in the dermatology, which is the melanoma, overutilized of imaging studies in melanoma. And then you've got two radiology ones below here, which again are just imaging confirmation of successful excision, and the other one optimizing patient exposure to ionizing radiation. So these are the 6 measures right now that are topping out in 2018. You'll have them on that list when you get your slide deck information. So it's just to be aware of it, and then to understand that, we kind of climbed to this list, and now things are going to start going. The government's going to start looking at things that maybe aren't doing what they need to do or too easy, something to that extent. And so if that's kind of where you're living, you may want to just be well aware of that on your reporting part. All right, so we're going to go ahead and move on into the advanced care information requirements, basics. So again, with this year, as in 2017, you have a 90-day minimum reporting period. So you could just do the 90 days if this is what you choose, or more, depending on how it is that you want to do that. You also have the ability to, the certified EHR technology is going to be certified. You can still use a 2014 or a 15 edition, or you also can report a combination of technologies. Same as what we were able to do in this last year, except for in our world, we ended up with the 2014 technology. In this year, 2018, we will be, you may end up being you probably will be in a combination, because of right now we're still 2014. Once we become 2015 certified in this year, then there will be a combination, especially on your CQM area, as what our ACI, depending on that time period that you're going to attest. And then you will also be required to report at least the base ACI measures, information that you have. So again, this year we had to report at least those 4 of the transition year, and I'll show that slide in here in just a minute. So the moving ahead, one thing to keep in your head about the advanced care information performance category, it's promoting patient engagement and electronic health exchange using certified EHR. So that's kind of where the focus is moving forward. So we got our direct messaging, future in patient portal, and just different types of information coming onto it. So that's kind of where that performance category is and always has been, but now we're moving into more of a enhanced on that as it moves through. So the advanced care performance category placed the Medicare EHR incentive program, which most of us know that. It gives you a more flexibility when you pick your measures than the Medicare EHR incentive program did. And in 2018, performance category is worth 25% of your MIPS final score. So this is kind of how your scoring category is going to look. You can earn in 2018 a maximum of 165%, but any score over 100% will be capped at 100%. So, you can go out there and score, like I said, high, but it's going to cap off at 100%. So this is just your measures. Your 50 is your required, 90 for the performance score of over and above, and then you've got the ability to earn some bonus scores with different options. So how is the base score calculated? I mean, more or less, when I say base score, is there's going to be certain requirements. And one thing to keep in mind is, again, we've got 2014 certification, we've got 2015. So the ACI base, when you use that word information, that is more geared towards the 2015 certification of ACI. And it requires the 5-score advancing information measures, which is, again, the security risk analysis, e-prescribing, provide patient access, send a summary of care, request, accept summary of care. So these are the required base that you would be required. So in other words, at the end of this year, if you decide that you're going to go ahead and the 2015 certification has been accomplished, you could report on this information here. Right now, you have the report available to you to be able to do it, but to keep in mind that until the 2015 certification comes out, would you be able to report on certain measures, information that's coming onto this? So this is just a copy of your ACI report. So in Practice Partner, you've got the ACI and the ACI transition. So the ACI-based information that comes on, and of course we've got the ACI Health Information Exchange, which, as we all found at the end of this last year, that with that health exchange means the direct messaging transfer of care. However, that has been changed so that it requires that there be, basically when you send that direct message out of Practice Partner, you click the return receipt toggle in the right-hand corner of the message window. But in order to get that numerator to score, the person that you receive that you send that direct message or transfer of care data to must open that and open the direct messaging, and I'm going to say read it, that it has to be open, and because that then sends the message back into the Practice Partner and will turn a variable into an R showing that it was received. So as I've kind of pronounced ongoing through this is that it's a much more of a challenge than it was in the past, so just kind of keep that in mind. There's no difference between this and the ACI transition report when we get here in a minute. So just know that moving ahead, the good news is you only have to have one of them. The bad news is that it's going to be harder to get. So you'll want to make sure that whatever communication you're working with, that you're sending transfers of care to, they're understanding that they're opening it and this information is coming back to be able to score on that. So you will want to be up to date on all patches for this. The next thing is the ACI Receive Incorporate requires return receipt. So it's just kind of what I was just saying, and that's just right over here on the left. So again, 2015 certification, ACI base, this is where it's going to come into play, is being able to return that. Once you've accomplished that, you should be able to get scores on both this report or the ACI transition, because you've got to do both of those to get the numerator on both of that report. The clinical reconciliation requires allergy, problem, and medication reconciliations, all three of them, and it can be done through the website or the pages, the windows, by manual, or when you bring in a transfer of care via a import medical summary and have it done there. Currently, it requires that it's be performed by a provider login. The provider's logged in, and in his or her setup, it says the above provider is this provider. This is on the docket to get changed so that clinical staff can do that moving forward. I don't know when that's going to be released on that, but they are working to get that updated so that it doesn't require the provider. Right now, it still does. So if you've been messing around with that, trying to get that, that's probably why, is that the provider wasn't the one logged in to be the information that comes on. And then the last is the patient-generated health data. This will require the 2015 certification patient portal, and that's where that would go in to be able to be updated for that particular measure. So understanding that with this report, there are certain things on here that you will not be able to accomplish until everything is 2015 certified and ready to roll on that for reporting. So we still do have the ACI transition, which basically goes it back down to the 4 measures in the security risk analysis, e-prescribing, provide patient access, and health information exchange. So that hasn't really changed from last year, except for now, again, with using the ACI transition, it still requires that return receipt information that we're seeing right up in here, as I just talked about. This medication reconciliation on the ACI transition is still just a plain old medication reconciliation, and it works as it always has. There's no change in information that goes on. So just keep that in mind, that the ACI transition, really the big change on that is going to be that the work on the direct messaging and getting that person who you're sending the message to open those emails and be able to read them to be able to get the response back. All right, so there's some ACI exclusions that we didn't have in 2017, which is kind of odd that they did come out in 2018 to Lyme, because basically a lot of people probably went ahead and got the direct messaging, which will hardly be used, whereas 2018 you can exclude from it. Keep in mind that with the 2018 Quality Payment Program, the final rule comment period added exclusions for the e-prescribing and health information exchange measures beginning with the performance 2017. We just didn't get them until now. If you qualify for these exclusions, you can still receive the base score if you report a 0 in the numerator and denominator for the applicable measures and claim the exclusion through the attestation or EHR reporting information that comes on. So it's going to work as it has in the past. You can exclude from these. You'll basically meet the base score, but you're going to receive a 0 performance score for the measures you've excluded out of. So the good news is if you went ahead and got the direct messaging, even if you could exclude, then it might be a reason to just keep on using it and moving forward on that, because then you could go ahead and wouldn't have to exclude on it, and you would go ahead and get points for it. If you're in a situation where you're never going to send e-prescribing, it is what it is, and you'll be able to exclude from that moving forward on that as it goes. So here are the exclusions, the same as the e-prescribing. Both measure sets is writes fewer than 100 permissible prescriptions during the performance period. Then the next one is send a summary of care exclusion, advanced care. Anybody who transfers a patient to another setting or refers a patient fewer than 100 times during the performance period. Again, then they've added the request and accept summary right into that as well, because it goes hand in hand. And then also down with the 2000 health information exclusion, it just includes the all of the aspects that would be able to come into that. So more or less in this year, 2018, you can exclude from the HIE measure if you write less than a fewer referrals out or information that comes in. As I will always stress till every day is that if I'm going to do an exclusion, especially with, this part of it comes in, make sure that you've got a plan set up as to how you're going to track that so you could prove that if they came back and audited you. So the best way would be to, possibly even still use your transfer of care or your referrals through order entry, and then you would have an order report that you could go ahead and produce very easily to show that these were the referrals we sent out, and it counted up to less than 100, and it wouldn't be a real hassle at the end of the year to go back and track that information. So keep in mind that you can do that if you choose to, but if you've already done it and you've been doing it, you wouldn't have to exclude. You only have to have one to go ahead and pass that measure, and you could have, again, you get extra points for that HIE. So, if you're already there, make the best of it and get extra points for that. The ACI performance measures for the performance score, this is just the extra points that you get for the extra measures that you may be doing, information that goes up to 10%. You can see on both sides information that pulls onto it. So it's just the extra bonus points that you could use to be able to go ahead and score on that in those measures, the ACI. Requirements for the bonus score, a lot of there is going to come in. You can see where on the left-hand side you've got bonus scores this year as well, up to 5% for information that comes on, and you still have those moving ahead. You also can see that if you are, you'll get extra bonus points if you're using a 2015 certification at the end of this next year, and then you can report certain improvement activities using the certified software. So if some of your improvement activities you're using the EHR to do that, you can actually get extra points as well for those bonus points. So this is just an overall of the bonus points on the ACI reporting measure. Okay. And these are just the changes, just the graph of the changes, which we have already kind of pretty much gone through information and the exclusions. All right, improvement activities. Basically, the reporting requirements are the height weight activities are worth up to 20 points. The medium weight activities are worth 10 points. 40 points are total required, 20 points required for rural HPSAs, non-patient facing, small practices, information that comes on, and full credit awarded for patient-centered medical home models. information that comes on. So a lot of that's kind of similar on there. What has changed, though, is they've added 21 new activities. They've modified 26 activities. They've removed one activity, and then additional activities eligible for bonus points for the ACI performance category. Now, when I started looking through this, I tried very hard to find that one removed activity, and I could not find it anywhere. And the 21 new activities and 26, I didn't have the time to go back and compare for you information, so I gave you a link. So you can go through there and just look at what it is that you're doing. So what you want to make sure is that the activity that you did in 2017, if this is what you're planning to do, moving ahead, then just verify that there hasn't been any changes or modified changes on that you're going to move, or the one that you're choosing, if it was going to be removed, make sure that it hasn't been. Okay, so we're going to go ahead and move into the cost performance category because, again, this is new that we haven't had to worry about, but keep in mind it's something that's been going on in the background all along. So you're not going to have to report on it. It's just going to be there for you, and it's all coming out on your claim information that's going out. So the automatic calculated for administrative claims data. So it's automatically being calculated in the background. The performance period is the calendar year. So they were already tracking that, and they did it in 2017 as well. So the benchmarks come from the performance year score. Information that comes on, and the score is the average score of two measures, the MSPB and the total per capita cost. If one measure does not meet the minimum case requirement, the score will be based on one measure. So basically, if you can't meet both of those measures, you're going to get just based on one measure information that pulls onto it. Cost performance category. The link right here at the top is for your fact sheet, information that comes on so you can read more of it. It kind of is a little bit complicated as you start reading onto it, but it's basically the goal of the cost measures is to go with quality care assessment so that the CMS can work toward better patient outcome and smarter spending at the same time. Cost measures are risk adjusted. To account for differences in beneficiary level risk factors that can affect quality outcomes or medical costs regardless of the care provided. The goal of the risk adjustment is to enable more accurate comparison across Medicare taxpayer plans that treat beneficiaries of the verifying clinical complexity. All right, so basically what you're looking at with the information on here is that the claims data, it ties back into what you're sending out to it, and they're looking at a lot of different information. You've got two components involved in here. You've got the TPCC, which is the total per capita cost measure, or you've got the Medicare spending per beneficiary measure, which is the MSPB. So a lot of this is kind of starting to play a role in that changing over for the performance, pay for performance type information that's coming on. For the TPCC measure, beneficiaries are assigned to a single Medicare tax ID, an MPI, that considers the level of primary care services and the clinical specialties that perform these services. And this really includes the PCP, the NP, the PA, and certified CNSs. Primary service care include E&M services, non-patient and non-emergency room settings, and initial Medicare visits, and the AWV. So where do these two cost measures? And basically, the clinician measure determines the Medicare pays for services performed by an individual clinician during the MSP episode, which we'll talk about episode here in just a minute, the period immediately before, during, and after a patient's hospital stay. So some of you may be working in that 72-hour rule, information that comes on, so that kind of plays a role in there. And then it also includes Medicare Part B and Part B claims during the episode. The MSPB measure is assigned to individual clinical and is identified by their unique MPI. So this kind of gets a little bit, I guess, boring after it comes into a while and to understand everything that comes on. So it's more that what you just need to understand is that they've been tracking your claims now. They've been tracking your claims all along, and in 2018, you do have feedback reports that came back from the 2017 measures that you can look at, and more or less what you probably want to do is look at those reports and kind of see how you scored it in the past. You weren't measured on them last year, and moving forward, and how it's going to allow you to kind of start becoming familiar with the cost measures. Overall, what this really involves is a lot of like risk management, your claims going out the door, how things are being coded, that kind of stuff there. So it's a little extra information. You don't have to measure on it, but it's something to start looking at and kind of seeing how you did in the last and how things may need to get better in this year information that comes on. So this is basically how it's going to go ahead and how they'll score you if the case minimum is attributed to beneficiaries is met. So they look at the minimum is 20 cases for the TPCC or 35 cases for the MSPB measure. And then to figure the cost performance score, the CMS will assign 1 to 10 points to each measure. They're also going to compare your performance to other MIPS eligible clinicians and groups during the performance period, not on the past year. The cost performance category score is the average of 2 measures, but if only 1 measure can be scored, the score will be the performance category score. So I talked about episode-based measures, and there again it starts getting a little convoluted again. More or less, the episode-based measures from 2017 are being retired. New episode-based measures are going to be tracked in 2018, but it doesn't affect us one way or the other. And they're going to notice a comment rule making process as to when these episode-type things are being tracked and if they're even going to include them in MIPS at all. All right, so this is just a little more information on episode-based measures. These measures are different and just kind of a little bit of extra information on that. All right, so we're going to go ahead and move on to the MIPS final scoring submission. And so you can see overall the pie chart that came up to it, so there's a little bit difference of that moving into this year. And then the new bonuses for the MIPS final score is complex patient bonus for 5 points, small practice bonus for 5 points, and improvement bonuses, quality up to 10 bonus points and 1 bonus point for cost. And then again on the transition, the 2018 PACE year options, these are going to be the changes in information that you have in here.
Susie, are you still there? Okay, folks, if you can just hang in there for a second. It looks like we may have lost Susie from the phone connection. Let's just give her a second to log in, and I'll ping her and let her know. Okay, just a quick update. Susie did get dropped from the phone line. We have been having a few technical issues today with the WebEx tool. So we're going to give her a second to see if she can get logged in so we can continue with the session. Hang tight. I think you're back, Susie.
I am. Thank you so much.
No problem.
Okay. All right. So here we go. This is back in the meet. Sorry about that. All right. So the final MIPS final scoring submission. The submission options you can see are very much the same as they won in the past, but I've highlighted the EHR and the quality data reporting. I've marked that as X. I want to just really stress the fact that the EHR last year, even in the 2017, we stopped updating the CQM tool and the QRDA files. And so the option to report out of your EHR quality data directly is not an option. And I kind of want to stress that because even as of today, we're still having people calling in that are trying to send that QRDA file, and it may or may not, I mean, it's at a risk to be able to do that. So just make sure that you understand that. Knowing that the CQM data cannot be reported, or it has to be reported for an entire year, is means that if you have not made any kind of choices to report your CQM data, you need to really get on the ball and get that done, because you're going to want to report for an entire year, and using what's in the EHR is not an option. And so I just kind of wanted to stress that information that comes on, is that reporting from here on out in the EHR must be done through a quality registry or a QCDR, and it is very different from the CQM tool. We all got used to that CQM tool. We got used to those numbers coming onto it, and we could see the data flow into that information. And so it was become a very comfortable tool. Moving forward in this year, as well as really in 2017, which now is almost over as far as reporting goes, you need to kind of start setting about and understanding and using tools that you've learned, that we all learned in 2017. So whatever option that you use, we partnered up with FigMD, and FigMD registration is open information that goes on. The one thing is that we've partnered with them, but if you're using another tool, the one thing that you need to be aware of is that they are certified and will be able to submit your data and information that comes in and how they're going to gather that data as well. When you go with a registry moving forward, and maybe you did use somebody last year and there was just a lot of confusion information that goes on, the one thing to keep in mind is moving forward, the CQM tool is not the same as data pulling out of your system. So you want to take a couple of things in mind when you get that set up. So the first thing is to, think about your workflow, and are you pushing CPT codes to the problem list in patient records? Because those procedure codes, CPT codes, really what comes into play is that the measures all look at the unique patient by the E&M code that's used for those visits. So if I'm not using patient records and I'm not pushing CPT codes down to the problem list, then those codes are probably going into a billing system. So then when you set that up there, the most important thing is, where is this registry going to find that data so that they can start giving you credit for that information that goes on. If your site has the ability with the practice management system, can they plug into that and be able to extract data from that as well? If you're working with a billing company, you may have to kind of look further and see if that's an option to be able to do that with a billing company. Or if you're going to have to change that workflow and start pushing CPT codes down for your measures down into the problem list so that your registry can extract that data. The current workflow mapping, also using health maintenance, clinical elements, progress notes, lab data. Are you using structured data? How are you using that? Or if you're using progress notes, how is your progress note structured so that the registry can look at certain data and be able to pull from that? Consistency when it comes to documented data is going to be the role there, and how is that being done? Understanding the measures to be reported and the requirements of these measures. So there again, what are the requirements of the measures that you're reporting on? The one thing is, with the CQM tool, we had that worked out and figured out, and that's what we all got used to doing. But there may be certain other things that a registry is going to need that may have not been recorded the same way in that CQM tool. So it's really important to start understanding how you're going to do that and be able to move forward on that, and how they're going to capture the data to be more successful and being able to get that data going on. If the plan, another thing that I've seen kind of on the measures coming on is, like, if there's certain measures that require a follow-up plan, information like that, how is that being documented in your progress notes now, or how are you being tracked on that? That's the kind of stuff, when you choose your measures, what you're going to choose, and then when you get with your registry, how you're going to show them the workflow as to what they're going to go ahead and collect on that, so they can get down to the bottom part of what it is that you're collecting. And then last but not least is, how are you going to manage the reporting on the back end? Do you have systems set up that you can do that? My favorite thing is using patient registries, because especially if you're using structured data, you can push everything down to that patient registry and give you ongoing work that you can go ahead and track information in the background to see what's being handled, so that if there's an issue on the registry side, you've got a way to go back in and kind of have some comparison data to be able to manage on that. So it's just very important moving forward, and I just want to stress the fact that the CQM reporting If you hadn't made that move or whatever it is that you did, or even if you chose to just, report ACI this day, this last year and move forward, you'll want to get really rolling on the setup of a registry to be able to extract your data and know how it is you're going to report, because it's going to be a full year, and you have a full year ahead of you to make sure that you're being compliant with that. Also, with the reporting the performance category through more than one submission mechanism in 2018 is not allowed. Currently, in 2019 and beyond, you will be able to report a performance category through multiple submission mechanisms. So I'm not really clear on what that means, if it means that you can, report data in bits and pieces all over, or just different multiple options.